Aloha, everyone. Welcome to the Queen's Medical Center West Oahu Virtual Speaking of Health Lecture Series. My name is Eric Barsatan, and I'm the Manager of Physician Relations and Medical Staff Services here at Queen's West. The topic for today's Speaking of Health lecture is osteoarthritis. Right now, throughout the presentation, we would ask all our viewers to be on mute. And if you have any questions, please type your questions in the chat box, and our speaker will answer them at the end of his presentation. This time, I am honored and privileged to introduce our speaker, Dr. Lafe Harris, our sports medicine here at Queen's West. Dr. Lafe Harris is a highly skilled sports medicine physician who specializes in a range of non-surgical orthopedic treatments and is dedicated to providing his patients with exceptional care. Dr. Harris is passionate about helping athletes of all ages and skill levels to stay healthy, active, and engaged in their chosen sports. He has extensive experience working with athletes in a wide range of sports, from high school and college athletes to professional athletes. Dr. Harris is highly skilled in the diagnosis and treatment of sports-related injuries and other conditions. He's dedicated to providing his patients with personalized care and works closely with them to develop customized treatment plans that address their unique needs and goals. Welcome, Dr. Harris. You may now begin with your presentation.
Thank you, Eric. All right, well, let's jump into something that a lot of people have here. We're going to talk a little bit about osteoarthritis. We'll touch lightly on some of the other arthritises. However, osteoarthritis is kind of the focus today. We're going to look more at how to treat it and different treatment options and whether or not they're effective. There are lots of options for treating arthritis in different parts of the body. We're going to focus mainly on large joints like hips, knees, shoulders. Some of this does pertain to smaller joints, and we'll get into that. All right, arthritis is inflammation or swelling. Like I said, there's lots of different types, and it depends on where it is or what's going on, to how you name it, what is the cause. But in the end, a lot of it has very similar outcomes, which is the joint gets worn out. As you can kind of see on the bottom here, the cartilage is nice and smooth on the left here, but then on the right, it gets kind of torn up a little bit, and that can cause some inflammation, swelling, and pain. There are many treatments for arthritis. Most of them give temporary relief, usually 6 to 12 months, but replacing the joint really is the only cure, quote unquote, to arthritis. Let's see here. There you go. Sorry about that. All right. So you can see here's the slide with the arthritis there. All right, so replacement is the only cure for arthritis. It's the only way we get rid of the arthritis in the joint area. If it's an inflammatory condition, then there isn't really a cure in that sense, as it's your own body attacking it. We're going to kind of start out, the Orthopedic Society put out a large review of the evidence, looking at the research, what is best, what is not best, what works, what kind of works. And that's kind of what we're going to be going through. We're going to be looking at these treatments from least invasive to most invasive and see which ones have evidence, which ones don't really have evidence, and which ones are downright dangerous. So let's go from there. So starting with braces and canes, canes tend to be quite effective. People tend to use them. Compliance is very low with braces. People tend to not want to use them, or they kind of rub on the skin, cause irritation, and people just don't want to have that skin irritation. Right. So after bracing and splinting, physical therapy is one that is often used. Physical therapy, is going to benefit the range of motion and the strength and the stability. Training, agility, and coordination are the most effective. Tai Chi has been found to be significantly helpful, especially in balance and preventing falls. Any movement is better than no movement. We often say motion is lotion. Supervised strengthening with a physical therapist is obviously the best, mostly because they can watch to see if you're cheating on the exercises or not engaging the muscles in the right manner or the right firing pattern. Home exercises are effective. Any kind of strengthening or movement is effective at helping. However, it's not as effective as physical therapy. All right. Weight loss is another option that people tend to pursue, and often patients will comment on this, oh, I know I should lose weight, but my knee still hurts. The truth is that weight is not the problem. Our bodies are designed quite well. We can, displace force really well. One of the major teams I take care of is rugby. As you can guess, rugby players are quite large. Most of them don't have knee pain. But, despite being, in the 300-pound range, 6'8", 6 foot, higher, and they're just getting a lot of beating up on those knees, but still they function quite well. So weight is not the problem. Fat cells do create an inflammatory hormone which they release, and that hormone causes the worsening of inflammation. It's very similar to smoking, which is why we kind of counsel everyone as primary care doctors, counsel everyone on stopping smoking as well as decreasing weight, because it does cause similar damage to the vessels in the body. And that same inflammation will affect here. I don't have a slide on it, but stopping smoking also helps decrease your pain. When you go to a physical therapist, they do have the option to employ modalities. Modalities are manual therapies, massage, acupuncture. So acupuncture has been shown to be effective. Laser therapy is occasionally called red light therapy. It depends on what you're using specifically. That can be effective. It's usually short term, doesn't, long term is something that you have to have or use often. You can get therapeutic red lights off of Amazon or from several different companies. What you should notice is that the lights will have infrared and red lights. Putting them on the area for about 20 minutes a day can decrease inflammation and swelling. TENS units can be helpful. A TENS unit is an electric or electronic pads you put on that fire the muscles. They send those electrical impulses to the muscles. They help decrease the pain by overloading the pain circuits. Basically, when you're sending so much information to the brain, you don't have the bandwidth or the ability to feel the pain as much. Another one that is really interesting is pulsed electromagnetic field. I've seen one of these. It looks like almost like a tennis racket with a hole in the middle, and it has basically a magnet spinning around it, and you stick your arm or body part, whatever, through that circle. Apparently it works, but mostly only for pain. It decreases pain, but spinning that magnet around can help. All right, so those are most of the non-medical interventions that we see. Moving into medications and things like that. Tylenol, acetaminophen is usually the most recommended. However, the research does not support that it does much for pain or for inflammation for arthritis. Tylenol can be very effective in other situations, but as a chronic medication, we used to always recommend 1,000 milligrams 3 times a day, for arthritis, and now it's just turning out it's not quite as effective. Most of the time we use it because it's safe, as long as you don't take too much. And usually too much for people over 65 means 3,000 milligrams or 3 grams, and for people under 65, about 4 grams, most people can tolerate. All right, so supplements that have been shown to have benefit are turmeric, ginger, chondroitin. You can often get glucosamine, chondroitin in a combined pill. I find the best place to get it, around here at least, is at Costco. They have some quite economic versions of it. The one thing you do have to think about is if you do have a family history or a history of melanoma, that you should not be taking it.
I can't hear him.
So
All I'm seeing is these.
Is your volume turned up?
Yeah.
Okay, down in here, is he doing it by Zoom?
No, he's doing it by WebEx.
all right, give me a second here.
Everyone, please keep on mute. Thank you.
All right, so if you do have a family history of melanoma, chondroitin does increase the rate and the speed of growing melanomas, which is not a good thing. Also vitamin D has been shown to decrease lower extremity injuries, increase proprioception, as well as increase the bone density. So that can be very helpful in decreasing the pain of arthritis. So most common medication that we find being used is an NSAID. Topical NSAIDs can be helpful. The nice thing about them is they don't affect your kidneys. They don't affect your they won't affect your liver. They really, putting them on the top of the skin can get into the area and provide local relief without endangering anything else. So if you have cardiac conditions, the NSAIDs are not very safe. We do want you to not take them if you're over 75 or if you have heart or kidney disease, only under the direction of a physician and only for the amount and the time that they say that you should take them. Short courses tend to be okay, but not chronic taking them after 75. So NSAIDs, we're thinking of things like Aleve, ibuprofen, Motrin, naproxen. All those are very similar, but the most effective medication in the research is a medication called diclofenac, which is now over the counter in a gel form, but also the pill form tends to be the most effective for improving function and decreasing pain. What people often call pain medications are narcotics or things that are made from the poppies. Any of the oral narcotics tend to be not effective. So how do we determine that? By giving them to people and then continuously, as we're following up with them, we ask them their pain score. And people who are taking oral narcotics tend not to have a change in their pain score. They may say, oh, I feel like it's working, but they continuously say, pain's at an 8 or pain's at a 6 or whatever it tends to be. And we tend to see that they don't improve function. In fact, they often make people more lethargic, and that can make them not move as much. Remember, motion is lotion, so that's what keeps your joints moving, so you want to keep moving. They also increase your risk of fall, which is very dangerous. Falling and breaking a bone is often quite detrimental to your health. All right, so here's one that's always comes and goes as far as insurance coverage and as far as, I guess there's always kind of an argument about it. It's not necessarily debated. However, it's not recommended for routine treatment. In other words, if you show up and you have grade 4 arthritis, at that point, grade 4 is the most advanced arthritis. At that point, it's time to probably think of more options like replacing the joint as opposed to necessarily doing injections. However, what we find the most is that people apply these a little bit too late, and that's why they tend not to work as well. So if you can come in and start them at grade 2 to 3 arthritis, we do see significant benefit. They do delay replacement for several years at that point. The FDA has approved it for the knee only. However, we can use it in shoulders, hips, knees, and ankles. I've never seen it be that effective in ankles. It tends to be very effective in shoulders and hips. And it really just depends on your insurance on whether or not they will pay for it in those other locations. But we know for sure, Medicare will cover it in the knee for sure. And it's kind of like an oil change, so you do want to do it every 6 months. It keeps that amount of gel and those processes improving over time. So they continuously get better as you have each successive injection. Another medication or thing that people use is called PRP or platelet-rich plasma. Basically, what we do is we draw your blood, we put it into a vial, we spin it down, and we take the part that is plasma with your platelets. That's why it's called platelet-rich plasma. This is not covered by insurance except for TRICARE West. It has been shown to be very effective. It is more effective than the Rooster comb injections or the Visco gel injections, and it does last for longer. So what we judge that based on a survey that people fill out saying, how much are you moving? How much pain are you in? It's a scale that determines that. And what we find is that at a year after getting these injections, people still have improvement from these injections. So instead of every 6 months, these injections are every year. All of our locations right now are working on getting PRP everywhere. We do have it in town. Right now, with our pain management department, does have it there and has access to it. Orthopedic surgeons will often use it in the OR to help after surgeries. Not covered by insurance, that is always, a consideration, but we try to keep it reasonable for what we're doing. All right, so speaking of pain management, the next level, let's say that you do PRP, you've done the gels and all that. The next thing to do is go ahead and burn the nerves. I know it sounds extreme, but we use these little, they're called radio frequency ablation. It's a needle that goes down into next to the nerve. Now, our diagnostic radiology department does use these, as well as our pain management department can both do these. So depending on your location and where you are, you may be able to get this done by either of those departments. Chat with your primary care. This can be very effective. Usually the nerves are heated to the point that they stop conducting pain back to the brain, which is helpful because you don't have pain. Remember, the only way to cure this is to replace it. So if you're not going to replace it, not feeling the pain doesn't really matter. We do notice that people do have improved function and decreased pain, not just decreased pain. And that's an important thing. Remember, motion is lotion. I want you guys to be thinking that every time you move from now on. All right. So after you've done everything, you really can't get the relief that you need, then it may be time to chat with a surgeon. There are different types of replacements and surgical interventions. One is the knee scope. They use some cameras. You can see how they have cameras and tools that go in through these little holes, and they can go in. They are effective if you have a specific type of meniscus tear. They're not recommended to treat the arthritis, though. They don't tend to be super effective in that area. And insurance often won't cover it unless it's mild to moderate arthritis. If you have advanced arthritis, at that point, it's likely better just to get the knee replaced. And a scope, like I said, will usually only be covered by insurance if you're treating a meniscus tear or something else in the knee. So if you have multiple injuries, okay, then you can move that direction. All right, something we have not been doing a lot lately, but is possible, is that you can get what's called an osteotomy. And that's where they go in and take a wedge out of the lower leg bone, and it allows your leg to kind of even out. Often people will wear harder on one side or the other. The biggest difficulty with this is that once we do this, it's difficult to do the replacement afterwards. So that's kind of why it's going out of favor. All right, some things that don't have evidence. Dry needling, which is just randomly sticking needles into people, as opposed to acupuncture, which has a set of specific points where you place them. Acupuncture, effective. Dry needling, there just isn't enough evidence. We don't know for sure. Right now, we don't recommend it. So if we're going to go ahead and take everything together and look at what we're doing, we got to remember, motion is lotion. After making sure that you're moving, so walking, the government recommends, 30 minutes a day of, mild to moderate intensity activity. So walking every day is great. Walking tends to be one of the most effective exercises for weight management, for health, and for, keeping your joints healthy. So motion is lotion. After that, if you're still having trouble or you're beginning to have trouble, it's often best to begin some physical therapy, try some over-the-counter anti-inflammatories, and see how you feel. If those really aren't getting you where you need to be, then it's time to probably come and see one of us here at Queens, and we can see and we can evaluate you for possible steroid injections. If the cortisone shots fail, which we do know that they tend to make themselves less effective the more often we do them, and we don't really want to give them any closer than 6 months because we don't want to damage the knee. I often hear this a lot. Well, I don't want a cortisone shot because I don't want to damage my knee. There's two considerations with that. One, you already have a damaged knee, right? You have knee arthritis that's already advanced to a point that is usually past the damage that you would maybe get from a cortisone shot. Secondly, most physicians, in fact, I don't know any who will give these injections closer, but the damage usually happens with repeated injections that are too close together. So most of us won't give any injections any closer than 6 months. In special circumstances, maybe down to 3 months, but that's, case by case. After those stop working or are not working as well, then you can qualify for the gel shots or the visco injections. Insurance does require that you've done at least 3 months of anti-inflammatories, physical therapy, and you've failed cortisone shots before getting the gel injections. They're much more expensive than cortisone, and so insurance would rather you go through that hoop first. They have been shown to be effective in delaying knee replacement for about 2 to 3 years. So that would be, six shots or so that you would usually get of these. And they're a series of 3 injections or 4 injections, depending on the insurance. What we've seen in the data is that they do have single shot versions, which in special instances can be effective, but tend to be less effective than the 3 or the 4 injections. In general, the more times you receive a visco injection, meaning in the series, the more effective the injection is. So here we prefer, I prefer the 3 or the 4 version as opposed to single version. All right. At some point that will likely stop working, especially if you're running out of cartilage, because you do need cartilage for the gel to work, which is why it's best in 2 to 3 grade 2 to 3 arthritis, not necessarily grade 4, okay? So what we notice is that then we move you along to PRP, okay? PRP is given in either 1 to 2 shots per year, depending, and the data shows that we can do it similar to visco with 1 shot every week, or we can give it as 1 shot, wait a month, and give a second shot. If the first injection relieves the pain to the point that they don't really have pain at 4 weeks, I don't repeat that injection, and we kind of just wait and see how long it takes for the pain to come back. All right, after that, we move along to doing the nerve burning. I know that just sounds horrible, but it's not as bad as you think, and it does provide significant relief. If you're curious if it would work, you can always come in. I can numb those nerves, and you can see how it feels. Usually you get about 2 to 3 days of pain relief with those blocks, and if they do work, then you'll likely get benefit from the nerve burning. All right, if the nerve burning doesn't last a minimum of 6 months, it's probably time to move along. Move along to replacement. So this should say no. So the new knee that you get here, it cures the arthritis because now you're walking on titanium. So here's a little diagram. Movement, good nutrition, walking you back through kind of the way that this pathway works. It's pretty standard. It moves pretty smoothly. And as long as you're coming to see, one of us, we're going to walk you through this process. We'll get you down. We'll get you to the point where we can find the most optimum treatment for you. Obviously, the least invasive, the better. We're just here to try to get people to move better and to feel better. We want people to be able to get back to living their life, and that's kind of the goal of what we're doing. And for some people, that may be a replacement. For some people, that's just anti-inflammatories and physical therapy. So getting evaluated is the best thing to do if you're having this kind of knee pain. So looking at a knee replacement, the reason we do delay it, as you can kind of see, and this is a little graphic, sorry, but it's what they do. They do cut the knee, the femur, into these angles here, and they also cut the top off of the tibia. And then what you end up with is this at the bottom where you have titanium, and it's like a plasticky thing. It's not really plastic, but it's similar. And what it does is these move together and they remove the pain. You no longer have pain once the bone heals. And so that's the cure, right? You can see here cutting out the bad stuff. So in the end, it's your decision. I've heard a lot of times I'll see patients and they'll come in and they'll tell me, well, they told me my x-ray was bone on bone, so I need a knee replacement. X-rays cannot tell us how you feel. They can't tell us how you're functioning in your life. So x-rays can be helpful in showing how far advanced your arthritis is and what interventions might be the most effective, but it's always your decision. And so when you cannot live your life because of the pain, it's time to get a replacement, or it's time, if we can't get you better with the non-surgical treatments. And a lot of people will fight against replacements. I know nobody really wants to have somebody cut your knee out and put a new one in, but it can be a quite effective option. Okay. All right. Do you guys have any questions?
Thank you very much, Dr. Harris, for the great presentation. Yes, if you have any questions, please put them in the chat box, and Dr. Lafe Harris can answer your questions. Let me see if anybody actually put anything in there. I received one actually while you were presenting. In terms of the age, they said this person's in their late 50s, but people tells them that you're too young to have knee replacement. Is there such thing as too young to have knee replacement?
Yes. I mean, we'll do it if it's the right option, but the knees usually wear out between 10 and 20 years. And so let's say that you're in your 40s. We expect you, average life expectancy is, into the 80s. So we're looking at 40 years of having a knee. We can't replace the knee 4 times. That's a lot, and removing that hardware can be difficult. So that's where the limitation comes in with the knee replacement. And often we have other options we haven't optimized or that we can optimize, especially in younger people, right? If you're in your 40s or 50s, NSAIDs are an option, which is a very effective option. Whereas, if you're 65 or over, you really can't use those as much.
See.
So I do have a question here. Do I need a referral? Oh, wait, hold on a second. It does ask if you need a referral from your primary care. That would really be up to your insurance. And so usually you figure that out with an HMO or a PPO. If it's a PPO, then I would say then you usually don't need a referral, but I'd always check with your insurance. All right. So
Another one just came through.
yeah, here's one about the hands. It says, my arthritis is in my hands. What treatments are recommended? So usually with hands, once again, motion is lotion. Heat actually helps quite a bit. Hand therapy, continuing to use your hands. And it depends on which joints of the hands. So if it's the whole hands, we would recommend, usually the diclofenac gel, which is over the counter. And it does have a little measuring stick inside. So you have to make sure that you get that measuring stick off the side of the box and you measure out the right amount of medicine or it really won't work. Okay. And then you get that medicine, you just rub it on your hands like lotion, and you can do that up to 4 times a day. It tends to be very effective. If it's in the base of the thumb or in some of the larger joints in the hand, we can do injections into them as well. We can't do the gel like visco injections. They only come really for the knees because that's what they're approved for. PRP, technically we can. It'd probably be painful, but we could probably get that done. And then they do have some replacements available for the hands. So hands are actually very similar, even though they seem kind of different. But I would start with the over-the-counter diclofenac gel. It tends to be very effective and pretty safe, right? So that's helpful. Let's see here.
Yeah, and there's actually more questions, Doc.
Yeah, I'm coming down here. Let's see. It says, I have a ligament tear in my knee and it feels unstable. I'm currently doing PT. I've also been told I have arthritis. Will the tear heal on its own? And what is the normal timeline? So it depends. Let me just see here. It says ligaments. So ligaments are some of the take a lot longer to heal. Usually, the most commonly torn ligaments would be MCL and ACL. So the ACL usually does not heal itself. The MCL, depending on the level of the tear, usually you just wear a brace for about 4 weeks, and that's where it heals. And then while you're doing the physical therapy, that helps the strengthening of the leg. And usually by around 6 to 8 weeks, people are feeling a lot better. We don't usually inject ligament tears with cortisone because that will delay healing, but we do inject PRP. Not into the ACL because we can't see it, but into the, the MCL and things like that, we can definitely do PRP injections, which do stimulate healing. So normal timeline is usually for a ligament tear, 6 weeks to like 6 months, depending on where it is and how far it's torn. Because there's, just like arthritis, there's 4 grades of tearing. Next question is, you mentioned weight is not necessarily an issue, so is weight training safe? Yes, weight training is in fact recommended. The motion is lotion. So if you can move more weight than your body weight, even if it's just walking, carrying, a 1 pound dumbbell, even that, something as simple as that can be helpful in building stamina and strength. And that stamina, strength, and stability will delay the onset of pain and help you function better. All right. So it says, I think I'm developing arthritis on my fingers, specifically my middle finger, and I use the lotion you mentioned when it's painful. Is there anything else that can be done to control the growth? So in the hands, a lot of times people will get like bone spurs coming off the sides. Unfortunately, currently, unless it's from rheumatoid arthritis, which they do have something called disease modifying agents or drugs, and what they'll do is those can slow the progression. For osteoarthritis, we currently are not using anything like that to slow the progression. And so you can switch and you can use something called arnica gel. Arnica gel is over-the-counter like homeopathic remedy. I used to be a rock climber, and we use arnica in the rock climbing community quite a bit for the tendons and ligaments, which it tends to be effective for. So that's kind of where I'd go with that. There really isn't anything to be done about the size changes in the fingers. All right, what are the long-term dangers or the dangers of long-term use in celecoxib and meloxicam? Heart attack and stroke are the number 1s and 2s. So those cardiovascular events is what we see in the literature. We're not exactly sure why, or at least I haven't been able to find a reason why in the literature that it does, but apparently kind of similar to the way it affects the stomach, there's some downgrade effects from blocking the pain in the COX. There are COX inhibitors, so they're called. So those, when you're blocking those, somehow you end up increasing your risk of heart attack and stroke. So that's my main thing I tell people, and the main reason. They can also cause kidney damage if they're taken in large amounts or over long periods of time. They can slow kidney function. They can also they make your kidneys work harder. So that has downstream effects. But then the other one would be stomach, right? You can get ulcers from taking them. Celecoxib and meloxicam tend to both be more selective. So that means that they are safer than the rest of them. They're the 2 that I would use in people if I need to use over the age of 65. All right, the next question is, I've been told that I have bone-on-bone arthritis and that I will eventually have to have a total knee replacement in about 2 years. Would it be better to do it now when I'm 2 years younger? No, probably not. I know it sounds bad, but the truth is that, optimizing your function, it goes back to that little chart I had, really it ends up being up to you and your level of function and your age. Right? There's nobody gets to tell you when it's time to change it. So the 2 years is just an estimate for you. That when looking at it, they can be like, okay, that seems like it's going to wear out soon. Or if you're doing the gel injections, like they know, we got 2 to 3 years of delaying knee replacement at this point. So yeah, it's all up to you. It really depends on your level of function and what other things you've tried. So that's what I would judge it on, not necessarily based on age. I mean, I've seen people in their like 75 get knee replacements and do fine. I've seen people in their 80s do pretty well. But it just depends. And that's also, it depends on your current level of functioning. If not replacing the knee makes it so that you're sitting down almost all the time and you're not moving, well, in that case, maybe you do want to replace it when you're younger because you won't lose as much muscle mass, right? Strength is how you stay alive and injury free. So, yeah. All right.
I think that was the last question. So again, I'd like to thank once again our speaker, Dr. Lafe Harris, sports medicine here at the Queen's West. So if you know anyone needing services, please feel free to refer them to Dr. Harris. Now, of course, I would also like to thank all of you, our virtual audience, for joining us today. And that concludes our Speaking of Health presentations for September. Again, the Queen's West Oahu Virtual Speaking of Health lecture series is a third Thursday of each month at 12 noon to 1 p.m. Please join us for the next lecture, which is scheduled for Thursday, October 19th. So on behalf of our Vice President of Operation, Robin Kalilani, our Chief Medical Officer, Dr. Ron Perota, and the entire Queens Medical Center West Ohana, again, mahalo nui lua. Thank you very much for joining us today. Till next time, please take care and always be safe.